Good morning, everyone. My name is Lucrezia Rovati. I'm a visiting research fellow in the Department of Pulmonary and Critical Care here at Mayo Clinic, Rochester. And with me today, there is also Claudia Castillio Zambrano, a research fellow in the same department at Mayo Clinic. Today, we would like to talk to you about our CERTAN program, which stands for Checklist for Early Recognition and Treatment of Acute Illness and Injury, and is an international educational and quality improvement initiative that offers a standardized approach to the evaluation and treatment of critically ill patients. Why did the CERTAN program started? CERTAN was developed to try to address the challenge that we have every day in the ICU with information overload. Indeed, in our daily clinical practice, based on our experience, we already try to find a pattern between all the data that we have available, trying to find what is relevant compared to what is non-relevant. Actually, CERTAN was developed for this with the aim of helping us distinguishing the unnecessary data from the relevant one that we need to provide the best care to our patients. Actually, in the last year, it has become clear that to improve survival of critically ill patients, the most important thing is the delivery of an high-quality supportive care. And this care must also be evidence-based. However, despite we know already this, there is still a struggle in having a standardized practice that leads to similar outcomes across different hospitals in different countries. This is the gap that the CERTAN program tries to address, delivering a structured, scientific approach to care delivery that is required to achieve the best possible outcomes for our patients everywhere in the globe. To achieve this consistent high-quality practice, what CERTAN does is similar to what other organizations and initiatives have done already, like the Choosing Wisely or the Zententivist Manifesto. This initiative, like CERTAN's, try to reduce the wasteful testing and imaging. You can see some examples here in the slide, things like routine labs, imaging, prolonged antibiotic therapy, unnecessary monitoring. We all know that all these items can just render the care we provide to our patients more complex without actually improving the management or changing patient outcome. So what CERTAN tries to do is to reduce the extra waste and unnecessary things that we do every day, while ensuring that we consistently do in our daily practice what is really important. So to do this, CERTAN, that started 10 years ago, aims to provide a standardized approach to critical care delivery. As I said in the beginning, CERTAN is a quality improvement and education project that provides basic standardized approach to critical care delivery, emphasizing teamwork, use of checklists to decrease the errors of omissions, and also to ensure that the important things are done consistently every day, and improving patient-centered outcomes, so putting the patient at the center of the clinical decision process. CERTAN curriculum is developed, putting together in a coherent framework all the scattered bundles that we can derive from other guidelines like ACLS, ATLS, Surviving Sepsis Campaign, in a comprehensive plan of care that we can actually use at a bedside. You can see here on the bottom right corner a map of the 34 ICUs in 20 countries that participated in the 5 years international prospective quality improvement trial that was published in 2021 in Critical Care Medicine, and that demonstrated that the use of the CERTAN approach resulted in better adherence to best practices and consequently in a reduction in mortality and ICU length of stay. What has changed in the past few years, especially with the additional push that COVID has given, is that certain that initially was blending in-person and online educational modules, now has transitioned to a complete online format that is delivered via multimodal platform that consists of online modules, remote simulation workshop, and also some video-enabled case-based coaching, faculty development, and quality improvement initiative. Here on the right, you can see the online programs that we have delivered in the last 3 years, or that are currently active, and how certain can reach across the globes in different countries, even during time of pandemics and of wars, like how it happens in Ukraine, as Claudia will soon describe to you. Each course is tailored to the specific reality where it has to be delivered. And indeed, we do a need assessment survey at the beginning of each program to change and blend our content based on the needs of the participants. And then we deliver them through the online modules and the remote simulation workshop I was talking to you about. And then at the end of each program, we also do a survey to ask to participants how we can further improve our program. Certain is based on 3 main pillars. The first one is coordinated early diagnosis and timely targeted resuscitation and stabilization of critically ill patients. The second pillar is the use of checklists and of a system-based plan that we can use both at admission and at every day during rounding to have a shared mental models that providers can use in teams and to improve adherence of best practices, as I was saying, both during the admission and the rounding. Finally, but probably this is also the key and the heart of the certain program, our third pillar is the delivery of patient-centered decisions. So we put the patient and the family at the center of the decision process, ensuring a humane and compassionate communication. Now I leave the floor to Claudia so she can explain more in detail these 3 pillars. Thank you.
Thank you, Lucrezia, for giving us a big overview of the certain program and how it was developed along the years. Now we're going to talk through the certain approach that it, as Lucrezia stated, has 3 main pillars. The certain approach is designed to integrate seamlessly with the ACLS and ATLS intervention, focus on primary survey, as you can see in the first 4 boxes, to address and treat immediate threats to life using an ABCDE approach, followed by a focused history and bedside test, including point-of-care ultrasound and point-of-care labs, to identify appropriate clinical care syndromes and address them with appropriate urgent interventions, and further diagnostic testing. During the patient stabilization, we also use the system-based rounding checklist to ensure we are delivering the best evidence-based critical care practices. And we repeat this checklist every day during rounds to ensure early aggressive de-escalation of critical care interventions as our patient improves. Throughout this process, we use tools like the Get to Know Me board so we can understand our patients as human beings and provide them with psychological, social, and spiritual support that they need, and help them understand their background and frame of reference as we work through them through these challenging times. As I was mentioning, the step 1 will be the primary survey that help us perform the initial assessment to address the immediate threats to life. If the patient is pulseless or apneic or gasping, we perform CPR and other standard advanced cardiac life support interventions. Otherwise, we systematically work through airway, work of breathing, circulation, disability, and exposure to identify and treat pathologies that otherwise will result in rapidly in our patient's death. At the same time as any ICU patient, it's important to start basic interventions, as we can see here in the certain procedure checklist. These interventions are performed at the same time as the initial assessment that will serve as a safety net to identify threats to life, and also they establish a route to administer medications and other therapies either through IV or intraosseous access. Other interventions include ECG, vital signs, pulse oximetry, and supplemental oxygen, and point of care ultrasound and labs. So the primary survey has been translated into English, Bosnian, Serbian, and of course Ukrainian. And these resources can be found in our webpage. As the second step will be the system-based assessment and plan, that we use this checklist on admission as well for treatment de-escalation, palliative care, physical therapy, daily rounds, so we can reduce the errors of omission. Based on all the information that we have gathered through the primary survey and the system-based plan, we can develop a program list to identify common critical care syndromes that we may encounter in the intensive care unit. This syndromes list help generate a differential diagnosis, and the certain approach has designed algorithms to provide checklist-based decision support for the best next emergent interventions and consults, so we can rapidly identify and treat the underlying cause of our patient critical illness, and as well avoid errors of omission. Something that Lucrezia mentioned, and it's really important, that when we talk about critical care, we shouldn't simply measure our success in terms of statistics of survival, but rather focus more on the quality of lives that we preserve or restore. The quality of death we provide to those who cannot return to a quality of life that is not acceptable for them, and the quality of human relationships we develop in the process. Therefore, we use the tools like the Get to Know Me board to meet our patients and their families, learning about their background. And in our eyes, this is probably the most important part of the certain approach, because it enables us to take care of our patients as human beings. We also have the Get to Know Me board translated into Ukrainian and Russian. Based on the experience that we have with the CERTAN program, we developed the CERTAN for Ukraine initiative on April 2022. It is a multimodal knowledge sharing and decision support platform for ICU multidisciplinary team working on the front line and across all Ukraine. It was developed by a group of international trauma and critical care experts in collaboration with Ukrainian clinicians with the support of the Society of Critical Care Medicine. It mainly consists of a series of case discussions and webinars on established approaches to battlefield trauma and critical care, held by a mixed faculty of experts, intensivists, surgeons, emergency physicians, and anesthesiologists from the United States, United Kingdom, and Ukraine. This simple approach, combining the use of common available technology and social media, as you can see here in this schematization, resources were used to provide critical education and clinical support, and it was adapted as well from our previous experiences during the COVID COVID-19 pandemic. Healthcare professionals were invited to participate in this community via an email invite, and the presentation topics were selected using a needs assessment survey, as you can see in the first two blocks of this diagram. We have held so far 14 teleeducation sessions and that were conducted on Zoom and have been broadcasted through YouTube. These interactive sessions were recorded and stored on the project webpage to allow asynchronous viewing and further discussion on the group chat. Most of the viewers and the visits to this dedicated website that you can see the link over here are mainly from Ukraine, and the content of these sessions were included cases presented by the Ukrainian faculty using the certain approach template, followed by a multidisciplinary discussion of evidence-based clinical management strategies by Ukrainian faculty and participating international faculty. This discussion was held synchronously during our webinars and asynchronously through the Viber chat. For more information, you can access again through this webpage and access to our library. You can visit icertain.org/Ukraine or scan the QR code provided in this slide. Finally, as Dr. Niven, one of our course directors, likes to say, it takes a village to be able to conduct and to perform this big program. And these are the certain team members for the current year. I want to thank them all for all the effort they have put to be able to perform this initiative. And as well, I want to thank all the members of the Certain for Ukraine faculty and the valuable contribution for the development of this project.